I want to get back to the kind of what do you do after immunotherapy, and ask Leora. There was some initial enthusiasm about IDO inhibitors, and we saw some recent data with epacadostat. We heard that there wasn't a very positive experience in melanoma with the IDO inhibitors, and what seemed to be a hopeful avenue of research has kind of turned in a different direction. You want to tell us a little bit about that?
Yeah, so there were multiple trials ongoing with epacadostat in every IO drug, really, and not just epacadostat. There were 5 or 6 other IO drugs that were in development, which suddenly shut down. And the data in lung and melanoma and head and neck looked really good at ASCO a couple of years ago, but Lisa Villaruz gave us an update at World Lung looking at pembro with or without epacadostat in the Keynote trials and ECHO trial. And that data just really was underwhelming. Mm-hmm. There wasn't a better response rate to what we know of historical controls. There was not a better progression-free survival. So, I don't think that there's going to be a big role for epacadostat either in IO naive or even IO failure patients until, maybe it is a biomarker issue in figuring out who should get what. But right now, nobody should get that.
Yeah, so it's a lack of enthusiasm at this point, given the totality of the data. Other thoughts? Are there any? I think you alluded to this before. Anything anyone is particularly excited about a novel IO combination after failure of it? I mean, right now it's really PD-1, PD-L1 inhibitors first line. What do you do afterwards? We talked a little bit about traditional second line. Any other thoughts about?
Now we have the Hudson trial in our clinic. After chemo IO failure, we do a rebiopsy with a Foundation 1 testing, and then we combine the PD-L1 inhibitor in combination with a targeted therapy. And I think this seems to be very, there's a hope, I think, behind this concept. Instead of giving docetaxel, to be more smart and try to target and IO. This seems for me a good future, and we have some really nice results from this trial already.
The LAG-3 data in melanoma looked really good as well in patients who are LAG-3 positive. And so we know that maybe that's a mechanism of resistance to PD-1, PD-L1, and those drugs are being looked at in lung now as well. So, that's probably the most impressive single-agent IO drug we have out there, but there are probably a lot more coming.
But stay tuned.
Stay tuned.
Yeah, nothing that's, at least in my opinion, nothing that really is rising quickly as a kind of the next new standard of care after IO. I think we have a lot of work to do in this population.